Good afternoon once again, and I'm sure it is a morning that side. Welcome to Civic Space TV. This is the Uganda Diaspora Show. My name is Lynn Komugisha, and I am your host today. We are on Facebook, we are on Twitter, we're on YouTube at Civic Space TV. And I want to bring you up to date with what's happening in the country following the demise of our Parliament Speaker. And it is reported that his body is going to arrive at Entebbe International Airport Sunday at 2 p.m. And it might be buried on April the 2nd in Omoro district. Some weeks ago, there was a stakeholders meeting. The diaspora, it was actually the 4th diaspora stakeholders meeting here in Kampala, and they had the presidential advisor on diaspora affairs, Mr. Abi Walusimbi, has called upon Ugandans in the diaspora. Mr. Walusimbi said that the government is planning to open up more professional job opportunities abroad as part of addressing the high levels of unemployment in Uganda. He said currently they're compiling a report that they will present to the president on which companies are externalizing labor. Then they introduced an app for labor externalization, something very interesting. The presidential advisor on gender and youth affairs, Florence Nachuala-Chinji, quoting statistics from Bank of Uganda, said the diaspora sector contributes about 1.2 billion to Uganda's annual revenue, and that is something we need to thank God for. State Minister for Defense, Jacob Oboth, has called upon Ugandans to desist from castigating their country, saying the habit affects Uganda's image abroad. And he said that some Ugandans with dual citizenship tend to talk ill against the government while in those foreign countries, tarnishing the image of the country, which he says must come to an end. And today in particular, we are very happy that we are going to speak about a very touchy issue. That has been a topic of, I think, the last 2 weeks or so, following the death of Jacob Olanya. We have seen dignitaries leave the country. We have seen government officials, fly out of the country for medical checkup. People with some money on them, leave the country and move to other countries for further medical help, medical check. And we are discussing today, we're looking at the challenges the Uganda health sector is facing and that medical tourism. It is a question that we have never found answers for. And we also want to understand, we also want to look into how the Ugandan diaspora can, chip in this. How can they help? How do they come in to address the challenges actually that the health sector in the country is facing? Today we have Dr. Solomon Mugisha Ondoma. I'm very privileged to host you today for the first time. We have Emmanuel Ainebyona. He's the senior PR of Ministry of Health. We have Kyomugasho Miriam, we have Albert Bakasara and Francis. They're all joining us today, and we are going to delve into this interesting conversation. Oftentimes, there have been challenges out there, there have been questions here and there have been comments here and there, and we need to understand, for how long are we going to go on with medical tourism in the country? But before we can get into the depth of that, Solomon, I'm privileged to have you today. Solomon, when we talk about all these things, what comes to your mind? What would you want to tell us? You have been abroad, you have been in the medical industry for a long time. Where is the problem? What do you think we can do? How, from your point of view, what is Uganda's problem?
Yes, thank you very much, Lynn, and the rest of the participants of this important conversation. And again, thanks for having me. Yeah, I have also followed in a peripheral way the events that have been going on with the late Right Honorable Lanya, our former Speaker of Parliament. And I think that what we have to understand is that this is not a new problem. Obviously, when there's an opportunity for people to express themselves, like the late Honorable's illness and eventual transfer to Seattle for treatment, then people get an opportunity to express their views about a chronic problem, as you've said. And I think that there are two issues. One is medical tourism is a business. And it exists because there's a demand for it. And I can tell you that people who leave the United States to go to Europe to get treatment because they think that the specific person who is the world leader in that field of medicine is not here in the United States. People Google a lot of information, and depending on what they see and if they have the means, they'll fly out of this country. You know, Hollywood stars will go to different places to get their plastic surgery work done. So that's one angle, is that as long as there's demand and supply and a geographic difference in the extent of specialist healthcare that can give, you're not going to stop medical tourism. It's a business model. So that's one aspect. Then the other angle of it is, when it comes to spending taxpayers' money on a specific individual for them to obtain very expensive medical treatment abroad, then that's a different discussion as well. And coming to that, I think that one is the reason we transfer dignitaries abroad is because one is the deficiencies within our own healthcare system back at home in Uganda. And those deficiencies tend to be in specialist care, critical care, nursing at the bedside, dependency on how accurate our diagnostic studies are. So because of those things, people will tend to leave the country if they have the means to afford doing them. The second arm of it is, I think that there's a general mistrust of our own healthcare system, or a lack of faith in the system, and some of it is propagated by our own leaders. And I think you may all remember many years ago, there was again another hot debate. I think the president's daughter had gone abroad to have a baby, and I do not recall exactly, but the president did mention something about not trusting doctors in Uganda, and he cited certain examples of, you know, misdiagnoses and how they wanted to cut off someone's leg and things like that. So if our own CEO of the country can express a mistrust of the system, that tells you that people, the ordinary person, will also not trust the system anyways. So I think that we need to improve our own healthcare delivery system. I've had people saying build more hospitals and institutions. I don't think that we lack the actual buildings of hospitals in Uganda. What we lack is adequate staffing with competent healthcare workers in our hospitals, equipping the hospitals to do the work they need to do, especially in critical care, managing really sick patients in an intensive care unit, and also training the specialists to do that job, and also just strengthening our own healthcare system back home so that you have a system that has guidelines, minimal requirements, and that there is constant supervision and appraisal within the system to make sure that people are sticking to those minimum required standards. What we do not lack in Uganda is planning. I think we have a lot of planning. We have a lot of blueprint. I've looked at the strategic healthcare plan for Uganda for the next 20 years. It's a very comprehensive plan that addresses the well-being of Ugandans and touches on every aspect of health that you'd imagine. But obviously, it's a question of implementation. It's a question of dependence on donor funds for financing our healthcare system. And it's a multifaceted problem. So I think in a nutshell, those are the challenges. The medical tourism is a reality. People will tend to go where they think they can get the best care. Perhaps something that I should also mention is confidentiality about medical care is an important thing. I can give you an example that in the United States, I'm a physician, but I'm not even allowed to access my own medical record within the hospital electronic medical record system. I have privileges to log in. I can look at my patients and other, but I'm not even allowed to look at my own medical records unless I request and they send me a link to log in differently now as a patient and not as a physician. So when it comes to privacy, I think that, word gets around very quickly in Uganda. And I think that certain dignitaries and big men and big women may not want everyone to know exactly what is going on in their health and the whole, everyone on the street to know what is being done to them in the hospital. So there needs to be a strict enforcement of what we call HIPAA regulations, or the equivalent of a HIPAA regulation in Uganda, that you cannot just divulge medical information about anyone, that every patient has a right to privacy and confidentiality of their information. So that's another reason I think people may prefer, especially important dignitaries, to go to Nairobi rather than be at Nakasero or Mulago to have their treatment. So there's some degree of confidentiality and privacy. So those are my initial thoughts.
All right, thank you very much, Solomon, for that. In a nutshell, you have really put down what our challenges are in the health sector. Emmanuel Ainebyona, I'm glad to host you today. I see you have joined us. We are looking at the increased medical tourism of Uganda. We're looking at the challenges that we are facing, especially in the health sector, to which you are part. And we are looking at also how the diaspora community, the Uganda diaspora community, can take part in this and help, in a way, maybe address the challenges that Solomon has highlighted. Equipping hospitals, training specialists, strengthening the healthcare system. A lot of planning. Strategic health plan is a very amazing plan, but implementation is the challenge. We have actually we have a multifaceted challenge. Actually, challenges, yes, and also strengthening the Hippocratic Oath. Yes. So, Emmanuel, I welcome you. We are trying to understand, why is there increased medical tourism? What is wrong with our systems? What is wrong with our hospitals? What is wrong with the ministry itself? The other day, not so long ago, you would not be allowed to leave the country for further medical treatment unless a certain board sat and approved you're moving to another country for medical attention. I don't know how that is going. And of course, we want to understand, is there really a problem, or is it just, because people have enough money to spend, or we have enough taxpayers' money to spend?
Thank you very much. It's the weekend, and fortunately I'm home, so you will excuse me for my appearance. But what I want to say is that Uganda, as Dr. Solomon clearly stated, has the best policies. And what is being done is ensuring that we translate these policies into a reality. That is implementation. And I can say Uganda is a work in progress, much as people might not be appreciative of the milestones we have made. We still continue to ensure that we translate these policies to improve our healthcare system. I can begin with the issue, for instance, of pandemics and epidemics. Uganda has been lauded world over for having a resilient system and also handling these epidemics better than many other countries. The issue at hand now is the issue of referral, medical referral abroad. We have a medical board that is tasked with ensuring they review each and every person who is seeking treatment or seeking referral abroad. We have also local guidelines in country on referral, the national referral guidelines. How can a patient, for instance, get referred from a health center 3 to a 4 to a general hospital, then to a regional referral hospital, to a national referral hospital like Mulago, until when they need, for instance, tertiary care like specialized heart care and specialized cancer treatment. And we already have the Uganda Health Institute, and also we intend to transform Naguru into a trauma center of excellence. The Uganda Cancer Institute is already a center of excellence in oncology care or cancer treatment in East Africa. So that is something we cannot take for granted. So if you say there is an increase of patients seeking treatment abroad, I need to know how many, during what period of time, because that is also a generalized statement. And I want to state that there is nothing wrong with someone seeking a second opinion if they can afford to seek a second opinion, either within the country or outside the country. So, and there are always also treatments that are still a work in progress. We have had Mulago refurbished and equipped to ensure that we are able to handle tertiary and also specialized care, things like organ transplant, that is kidney, liver, cornea, of which is also work in progress. And now already a registration is before Parliament to discuss and feasible. Already now the equipment is already installed. All the specialized diagnostic equipments are available. The experts have been undergoing trainings. We have a lot of scholarships that are supporting Ugandan health workers to acquire more skills. I can give an example of Uganda Health Institute. The Uganda Health Institute, what has been lacking is just space. But we have all the surgeons and the cardiothoracic surgeons you can ever think of who are able to perform any open and closed surgeries. The only challenge has been space, and now they've been allocated land, and they are going to work on a complex that caters for more operating theaters, more recovery rooms, more ICUs to enable them to operate properly. So it's not that government is not doing anything, because now we are seeing an increase in the number of patients who are of advanced age, who need tertiary care for the heart, tertiary care for organs, also need surgery for cancer, which we need to continuously ensure that we offer this treatment. But also this is based on how much money we can have to have all these plans realized. But I can say that we are doing whatever we can do as a country to ensure that we achieve, we attain, sorry about the noise, there is a phone ringing, so such that we can achieve that kind of tertiary care that is taking our citizens abroad, and also reduce on that foreign currency. That's partly what I can say, is that all these are planned, and already some surgeries can be done here, but some kind of specialized treatments, that's when people seek additional opinion or specific surgery. For instance, there is a machine called a PET scan that detects whether someone has recovered from cancer or not. That machine is not yet here, but allocated money to buy it. So some patients, for instance, cancer patients, you find when they have traveled to seek that specific diagnostic equipment. But others, like the linear accelerator machines to offer radiotherapy, the brachytherapy machine, the MRI, the CT scans, all those machines have been acquired. So we continue to acquire technologies. There used to be a lot of complaints about our old machine, but you no longer hear about people now complaining that they have failed to get radiation treatment as a treatment for cancer, because already now we have installed capacity of a linear accelerator. We have 2 brand new functional cobalt machines. We are acquiring another 2 this financial year. So if we continue to equip our facilities and also continuously train, we have a number of Ugandans who are training all over the world in neurosurgery, in heart treatment, heart surgery, in organ transplant. So all those, once they have concluded training, also in critical care, we've been having a challenge of critical care, that is ICU patient management. But we have now had a number of health workers trained in critical care management. Even for COVID alone, we have had a number being trained, because COVID, one of the requirements was critical care treatment within the ICU. I can submit for now, but I want to appreciate the preamble that was given by Dr. Solomon, which was spot on. Thank you.
Thank you very much, Ainebyona Emmanuel, who's the senior PR of the Ministry of Health. I like that you give us a picture of what it looks like from your point of view, because you are within that sector. Most of us who are outside, we don't necessarily understand the goings on there. But thank you indeed. However, I would want to indulge you. Since the outbreak of COVID, we have seen that many countries, but particularly Uganda, the health system came to the fore. So we started noticing that we have challenges, bigger challenges in the health system of the country. In this period that COVID happened, as the Ministry of Health, what were the challenges then and at the start? What have you improved on?
Yeah, specifically to COVID, this required that we needed treatment to expand our treatment in intensive care management. That came with the need to enhance our oxygen generation, storage, and we are now talking of additional oxygen treatment plants for our regional referral hospitals, our national referral hospitals. We are looking at the cryogenic tanks that can move oxygen in large quantities. We also worked with the private sector that already had existing capacities. So that talks about the public-private partnerships that this pandemic came with, where we worked with the private sector to solve the existing challenges. So and also training. We've had a lot of investment in training, critical care training, infection prevention control. And now we are even talking about vaccine development, setting up capacity to develop a vaccine. So it's not that Uganda is really not moving forward. We are moving forward, and we are better. This pandemic has left the healthcare better than it was before the pandemic, given that now you talk of an ICU bed in Kabale Referral Hospital and you find it there. It wasn't there. So all these efforts to improve treatment, given now that the trend of non-communicable diseases seems to be on a rise. where patients will need tertiary care that is highly specialized.
All right, thank you very much, Emmanuel, for that. I want to go back briefly to Solomon. Dr. Solomon, with the challenges that you have, put before us as a country that you think we are facing, and from what Emmanuel Ainebyona has spoken about, what do you pick from this? I want to pick your mind from so far, what you said and what Emmanuel has talked about.
Yes, thanks, Lynn, and thank you, Emmanuel, again for that very informative discussion so far that you've given us about in general healthcare delivery in Uganda. I think that one of the biggest challenges in Uganda is the predictability of getting quality health care. If your child had an asthmatic attack in the middle of the night, or if your father or spouse had a cardiac arrest in the middle of the night, is there a predictable way that you will call an emergency service that will come and pick that child or your parent in an ambulance and get them to a hospital, and there will be a team waiting to attend to them so that there's a predictable outcome for them? That's a systems problem. If you get an accident in the middle of the night on any road or any highway in Uganda, is there a predictable system of an ambulance coming to pick you up, taking you at a trauma center, meeting a trauma team ready to attend to you, resuscitate you, and manage your problems within a short window of time? We don't have that predictability, and that's a systems challenge. The healthcare system in Uganda is set up in such a way that you can get some kind of care both in the private and public system to a certain degree. It's just how predictable that system is, and so that's a big challenge. It has to do with standardization, referral patterns. Now, equipping hospitals is one thing, and then having the actual staff there is another thing. Staffing for doctors in Uganda in the hospitals generally at about 60%. Anesthetic officers is at about 30% in Uganda. Pharmacy technicians at about 40% in Uganda. So there's a very critical lack of specific staff members. I can give you, in an ICU, you typically should have a ratio of 1 nurse to about 3 patients. And I do come to Uganda every year, with the exception of maybe 2020, and I do participate in doing, neurosurgical cases, especially at Mbara University. And it's not unusual to find 1 nurse taking care of all the ICU patients, really critically ill patients on ventilators in that ICU. So there's no way you can take vital signs and do a clinical exam on certain sick patients every 1 or 2 hours as 1 nurse in an ICU. The other thing is that we have a lot of equipment in Uganda that sits in the corner of a room and gains dust, simply because when it started working, it broke down and it takes about another year to have it fixed or repaired. So equipping is one thing. The constant supervision and maintenance of equipment is also another thing. And I think that's one area of improvement that we need. The other thing is regulation of private healthcare in Uganda. If you have a hernia surgery in any private hospital in Uganda, there's no predictor of knowing what you are going to pay. And that is something that Mr. Ainebyona, the Minister of Health, have to work on. Is there has to be a regulation so that exactly you don't get one bill from one hospital, another bill from another hospital. So there's a certain standardization or rough estimate, and actually a regulation that people cannot be charged beyond certain limits of money. And going back a bit to medical tourism, and this is something that I would like Mr. Ainebyona to answer to. There's an inbuilt incentive in Uganda for specialists to refer patients to certain countries like India, because they're paid a commission on every referral they make. So that incentive has to be taken away. As you said, if there's a board that sits and regulates these referrals, it should not be incentivized by money paid to them because they refer the patient to a certain hospital in India. that creates a disincentive to optimize those various services in our own countries, or to go through a more regular process of having people sorted out in terms of who should go abroad to get that treatment. So I think that those are the issues. Again, the plans are there, the structure is there, the implementation is a different thing. Of course, we have not even touched, the corruption within our healthcare system, the absenteeism from work. People show up late and leave very early. The dual private healthcare and government hospital employment is a problem. Yeah, those are my observations. That again, we have the blueprint. There are many things that are low-hanging fruit that we can improve. Let me give you an example. If you had a relative at Mulago Hospital right now, and you want to know how they were doing by speaking to a healthcare worker, either a nurse or a doctor, can you pick up the phone and call a general line at Mulago at 1 o'clock in the morning, and they get you through to the nurse taking care of that patient, and you find out what the patient is doing? We don't have that mechanism, or even knowing who the doctor on call is. Now, some private hospitals like I've called TMR as late as 1 o'clock in the morning from the US, and someone picks up the phone and even gets you through to the doctor on call about a patient that you want to send to them in the middle of the night. So that's a systems issue, and it's not just about money, it's just about building a culture in which you build these efficiencies within the system. Thank you very much.
Very wonderful. Thank you very much, Dr. Solomon. Emmanuel, I hope you have noted those. I'll come back to you later as you put together what you can say about what Dr. Solomon has told us now. Miriam, I understand also Francis is in attendance. I want to pick your mind. So far, we have heard from Dr. Solomon, we've heard from Emmanuel. We are trying to understand the situation at hand and how do we move forward. Miriam, in your contact, in your engagement with the Ministry of Health, in what you have encountered, what do you think is the problem? Why do we have continued, it is not increased, it is continued medical tourism of Ugandans?
Good morning, good afternoon, everyone. I think as Ainebyona and Dr. Solomon have said, it's like whoever can afford it, have a right to have it. That's what it is in capitalist setting. It's like demand and supply. But the concern goes to those patients or the dignitaries who use taxpayers' money at the expense of other citizens. I would like to think that there is a better way we can do this. Buy the equipment that Ainebyona said is missing in the hospitals, cut down on the costs. I mean, the VIPs care about confidentiality and whatever, but they can chip in their pockets because they can afford it anyway. So get the government money to fund the citizens, the taxpayers, let them get the services they deserve and pay for instead of spending exorbitant amounts on the VIPs and the know-who's. Because we know in Uganda, I mean, we don't have to see corruption every day, but we know it's about who you know. If you know someone, you get the services. If you don't, you don't. Even when there was COVID, even when there was, COVID was at its peak and it's really highly contagious and it was an emergency, some people couldn't access the ICU if you don't know anybody. If you can't call, you can't get treatment. Even when the vaccine came, it was apportioned according to those who know who until when the amounts became available to other people. But it started with the know-who before it went to the rest. Yet all Ugandans deserve better. I want to refer to the real setup, the mindset of Ugandans of thinking that if you are VIP, you are entitled to something, but citizens are not. I think we need to elevate the level of the ordinary man. If you are a Ugandan, whether you are a president or I am a farmer, we are all entitled as citizens. Okay, the president is gonna get an extra VIP treatment, but there should be a basic minimum level that when my sister in the village is having maternal problems, she can't even get a painkiller, but the president can get millions and millions for treatment. That is social appetite. That is an injustice, and we should try to uplift and change on that mindset. I know it's something that we take for granted, but it's not right. For instance, why did we spend millions? I hear it's almost like $400 million to fund a non-existent hospital in Lubowa. I don't know if it's even there, because I've not seen anything to show that there is a hospital. Ever since like 2017 up to date, nothing shows the expenditure of that money. Yet the government spent that amount, the money that should have built so many healthcare centers, 4 and 5, or maybe referrals at the regional level, to avail the ordinary people resources, the much needed resources. But our mindset was thinking about the VIPs already. That's the mindset that is so wrong. People, if a minister wants services, let her go to a referral hospital that a farmer can go to. She can get extra if she can touch in her pocket and fund her extra. There shouldn't be an exception to what I can get and what the permanent secretary or the minister or whatever can get, as long as it's government funded facility. But again, another issue goes to what Ainebyona mentioned, and I felt is something we can also change. I want to be positive. I'm looking at the solutions. I don't want to go back into the problems, because we all know the corruption and all that stuff. Let's look at the solutions. You say Ugandan hospitals are not facilitated both in manpower and the equipment. But we all know that the biggest challenge in Uganda's staffing in the medical care is the payment, the remuneration. Most people go abroad for greener pastures, and I think Mr. Solomon Ondoma can confirm that, for better pay, because we cannot pay them. Would rather pay RDCs and the military and buy fighter jets instead of paying the medical officers. Yet when we get sick, we again run abroad where the people who have gone for greener pastures are serving, and they are the same people who treat us. So why can't we shift that funding and try to remunerate our medical officers and the manpower that works in the health sector at the same rate, at least based on the regional remuneration, so that we stop the brain drain. We are training. We have so far so many schools of medical and healthcare institutions today. We have so many. Barara, I mean, everywhere you go, you see a nursing center, you see, and then there is Morago, there is this and that. But where do those people go? And why are they not in government hospitals? Why are they not in private hospitals in Uganda? Because they are facilitated much better abroad. And we can do at least a lot better by taking part of the budget we spend on dignitaries and facilitate the medical staff so that they can get the same services back home, and other people can benefit instead of benefiting a few individuals with the few of the resources we have. Another issue I would like to highlight is the medical tourism thing of if you can afford, you can get. For instance, Dr. Ondoma talked about the plastic surgery, whatever. I think that's a luxury, but it's there. For instance, today, Uganda has some of the youngest middle-class citizens who would like, that extra service. But if we know it's a service, why don't we market it as an investment sector and we keep that money home? put the services that people want back in Uganda and keep the resources back home. You market it, just call for whatever, or train people in that sector if they need it. But that's a luxury we really, that's like the extreme of luxuries, but it's an example. But we can do a lot of other services just to keep the resources back home, keep the services cheap. And then maybe one of my last points I wanted to highlight is subsidizing the private health facilities. Mr. Ainebyona, I think the government should think about, we have so far so many private clinics and they go to the village level where sometimes the public facilities are not present. Why don't we think about facilitating, subsidizing some services like maternal health care, reproductive health services, child care, treatment of common diseases like malaria? Maybe we provide same way like we subsidize private education into private health providers, so that we cut the cost to the ordinary person and we give them the services that they much want. For instance, you can put, say, the government medicine at the, or you give the private clinic operator the right to prescribe some, say, antimalarials to a person, and then that person can get the medicine from a government facility or something like that. I think there should be a way to subsidize the cost of health care to the ordinary person. The resources are there, but the facilities are not there. So in order to mitigate that gap that is there, why don't you think about public-private, like kind of operation for the healthcare, so that the ordinary person can get the services that they much need at affordable cost?
Thank you, Miriam, Dr. Solomon, and Ainebyona for the enrichment conversation you have given us. Yeah, for sure, like how other panelists have said, our health sector needs a thorough diagnosis for us to be able to get the best out of it. I will also, as a Ugandan, condole with the family of the late Speaker of Parliament. It was a big loss for the country. And I also regret whatever events that unfolded before his demise. Although, as how Dr. Solomon had put it, we need to ask ourselves that there are underlying factors or conditions that even forcing people to act in a way that is not in line with our African traditional norms. Having said that, Dr. Solomon and Ainebyona we are talking about medical tourism, and we all agree that it is fine, whoever can afford. But what we are saying here is who pays for what. Although Ainebyona is asking us that we should give the statistics, I don't think that for us, we are the people to give the statistics. It is rather the ministry to give us the statistics that, look here, these are so many people that have gone out for medical tourism on recommendation of either government. Our concern is who pays and who is supposed to access this service. So that is our major concern. And if in any case, we are always bothered by how much is always spent in relation to what is needed, maybe at a small government hospital in a district that could have helped in one way or another. Miriam hinted about the Lubowa incident. For sure, nobody seems to be bothered. That's the way how Uganda should be. And we are saying, no, that's not okay. There is, in one way or another, how we can improve these services. Or if we have a government that loves its people and respects accountability, come out and give a statement. Come out and explain, since our government is supposed to be answerable to the people. Emmanuel, you hinted about the way how you handled the pandemic. I absolutely agree with you that the way how the pandemic in Uganda was handled was the best, but I don't agree with you how it was managed. There was total mismanagement of the whole process, scandals where people are being injected with water. The Minister of Education, Minister of Health comes and then says, it is okay, don't panic. So all that is what is crumpling our education sector, and it's what we are saying, can we clean up? Dr. Solomon talked about the kickbacks. You are aware how people go and procure drugs that are about to expire, even before, by the time they are transported from wherever, whether India, reaching Uganda, they are already expired. And then another budget is drawn how we should dispose them off or ban them or whatever. I don't know what is done. These are the things we are trying to say, look here, this is not okay. You must be aware that there are, most especially, some of the drugs from India. You'll find some of them are fake drugs. But we are saying, can we move a step and see how we really work out some of these things? So we have a lot of things that we need, but also, okay, why can't we improve Ainebyona? Maybe you have some statistics of how many people from other countries, from Kenya, from wherever, that come seeking, so that we also become a destination for medical tourism. Let's also put that's what we are also looking at. I'm glad that you have talked about the Heart Institute. Yes, I do remember I had one of my students who benefited from open heart surgery at Mulago Hospital. And those are some of the things that we need. I'm excited when I had the whole plan that is there to upgrade it and make it as big as possible. But our concern again is that sometimes you find, if it is the person who is accounting or whoever, but out of that project, it has constructed even a hospital that is, or buildings that would even house a given hospital somewhere as in form of corruption and so on. So those are things that we are trying to say, what has gone wrong? Look at during the pandemic, people were cruising in huge vehicles and so on, at the expense of interns, at the expense of people who were on the front line, and yet money is designated and nobody even bothers to pay them. Think of a doctor who is hungry. Think of a doctor whose child has been chased from school fees, is not going to school fees. Think of a doctor whose parent is also sick somewhere, or they can't afford food, and is the one standing before you to go and operate you. What result do you expect? Does that doctor have a concentration of and making precision of the procedure the doctor is going to carry out? So these are cross-cutting issues, most especially to do with when it comes to management. Recently, I saw the issue of arresting the head of Mulago Hospital. But what I want to pick out is that the audit, was it from 2017? So I was asking myself, such a huge hospital in Uganda, it takes since 2017 up to date, you don't carry out audit? And I'm like, are we not joking sincerely? Where we are dealing with. So if it happens where life is being dealt with, what about in the president's office? What about in the Minister of Education and so on? that itself opens us, and then either other people can go an extra mile to begin making speculations. So we need to be people in the diaspora for us to understand us from where we are coming from. I don't know whether because I was always on and off because of my computer, I don't know whether Dr. Solomon talks about the telemedicine. I don't know whether it is the right time. But how can we take advantage as government or as Uganda of our doctors who are outside the country? Is there any way that they can keep helping? I don't know, I might be wrong. I still believe that there is when I have maybe called a doctor and said, this is how I'm feeling. And a doctor even prescribes for me that, okay, this is the whole situation. You need to do this and this. We need to increase these services. Like as how Solomon said, that if who is on a call that you can call and talk or access this information freely without struggling. So I think we need to move a step, Mr. Ainebyona, than politicizing the health sector. Because if we take that route, then we are doomed. We are doomed. So I would think that for me, one of the suggestions that I would give, it's not that when you consult or you ask somebody that you don't know. Let's engage our doctors that are abroad, so that as Uganda we tap into their experience, and then we have a robust kind of medical system where we know they have great ideas, they have seen here how things are being done, and so on, and then how we can move forward. Then lastly, in the opening remarks of Lynn, talked about both warning us about castigating Uganda and so on. If I may echo the words of Bakasara, we always say, since Ugandans were ambassadors of our country, give us a good story to sell.
Yeah.
Yeah,
Okay.
if there is no good story, we should know that there is explosion of knowledge, information.
Okay.
Even before I go ahead to defend government on XYZ or to promote it, somebody has already put on social media maybe how maybe a policeman was torturing people and so on. So how will Dr. Solomon convince a friend who is a doctor here to go to Uganda where people are being beaten on the street as if they are beating dogs? Leave alone that. Government does not come out to clear some of these allegations, like the organ extraction in Uganda. They allege that doctors are doing that. None of the Ugandan officials has come to clear the air. So it could be some lucrative business going on. The only thing we had was now to come up with the law that it is okay, people can donate their organs and so on. But first talk about the other problems so that Ugandans gain confidence that the rumor we are hearing of, that when you go, or some of the doctors in Uganda are part and parcel of the cartel that is extracting body organs and so on. And then we gain confidence in our medical services and so on. These are pertinent issues. And you know, once a lie is told 1,000 times, it appears the truth. Thank you.
All right. Thank you very much, Francis Kamuhanda, for your insights on that. Emmanuel, I want to give you about 5 to 10 minutes if you have any responses to our previous speakers, and then we can go into the real matter of the day. How can diaspora come in? How then does the diaspora invest in the health sector? What opportunities are there for them? But for now, Emmanuel, you have about 5 to 8 minutes of you responding to some of these queries that came up.
Thank you very much, Lynn, and thanks to Kamuhanda for his submissions. I wish to go back to Dr. Solomon assertions where he talked about the need of a proper emergency care system that can enable someone to check on the patient involved in an accident. We have last year, towards the end of the last year, we had a policy on emergency care medical services that was approved and passed by cabinet, and we are in its implementation to an extent that during COVID, most of the evacuations were done using government ambulances, and the turnaround time of saving lives was very excellent. And this also follows investment. So, and one area that needs to be invested into is emergency care medicine, emergency medical services. We are building an ambulance system that works on a system that can be able to geolocate, for instance, if an accident has happened through a call center system, through an emergency response system, the ambulance is able to locate the exact locations where the incident has happened. The patient is evacuated, worked on by the emergency medical team. They are in touch with the hospital where all that is happening of the emergency medical services. He also made an assertion that there is an incentive for referral abroad. I think that is something that I'm hearing for the standing. I would read the Director General Health Services to know whether really that happens. I didn't know about that incentive because mostly the referral that is given is after a senior consultant has referred and the case is tabled before the medical board, and they say this person indeed is seeking for a treatment that criteria. So this issue of saying that those who refer may be private citizens who want to go abroad, but all those referrals need to be first discussed within the medical board for referral. That should be the standard. But we are aware that, of course, there are companies that act as brokers for that need patients who contact these families privately. And still, I can say, if someone can afford and they are willing to go and seek for a second opinion, there is no problem in that. Only that all the patients who are using taxpayers' money need to go through the medical board for approval of whatever condition they want to go have treated abroad. And the guidance that this treatment should not be, it should be when this specific treatment is not available in country. But of course also it is subject to abuse. But all these are things that we need to look into and investigate because there is no smoke without fire. So we need to ensure that we investigate, but still, there is the destination of region. I said the Uganda Cancer Institute is a center of excellence. We have patients who come as far as from Ethiopia, Eritrea, Rwanda, DRC, just to visit Cancer Institute. Just to visit on a common day, and you interview and ask patients who have come to Ethiopia seeking for cancer care, because Uganda has distinguished itself into that. And regarding cancer care, we are decentralizing to have cancer centers in Mbarara, in Guru, in Mbale, and in Arua, such that we reduce the congestion at the Cancer Institute. The congestion such that patients do not have to travel many long distances, have to have expenses into accommodation, but also looking into having hostels, and those are also areas where people can invest. If you can invest in a nursing home where cancer patients who are waiting for their appointments can be also have critical care nursing, what is it called, home nursing. If you can have a facility where someone can have their loved one who is, let's say, on chemo, who is on a session of radiotherapy, have treatment and proper attended to. But also within our government plan, we are looking at expanding our facilities such that when you visit the Cancer Institute, you do not find a number of patients waiting in the compound, and also the whole situation at times gets traumatizing, but the care is there. There have been a lot of success stories told out of the Cancer Institute. People who have had their tumors operated, people who have concluded their sessions for chemo, who have undergone radiotherapy, people who have had breast cancer surgeries. But unfortunately, the main challenge is that most of our patients report late when cancer is already in advanced stages, of which calls for more sensitization, more education, and more regular checkups, which is our role to ensure that we do health promotion and education. So the other issues of recruitment, it still remains work in progress based on people who are qualifying for these specialties. I admit we have a challenge with anesthetic officers, and even in an effort to recruit, most of the adverts have not attracted candidates. During COVID, we needed over 40. About only 7 managed to apply for the position of anesthetic officers. So we need to continue with our scholarships. If it means bonding health workers who have benefited from scholarships to attain specialized care in in heart treatment, in oncology, in specialized like IVF for the ladies who have challenges with the reproduction. But all these, as I said, also have to be guided by registration. The previous speaker talked about the issue of organ harvesting. In Uganda, all those remains unfounded claims, but we've had those migrant workers who have had challenges abroad of these of having their organs extracted, but I don't think this is happening in Uganda. But also as a way of ensuring that we make treatment like organ transplant available, we need a registration to guide all the process. The issue also of IVF within the women's hospital, it's also a role that has partly, because some of these things cannot happen when there is no proper registration. There's an issue that was raised on the need to support the private healthcare facilities. We already have primary healthcare grant we give to facilities, including private facilities. That's why there is subsidized immunization for children in all facilities, both public and private. So we also second their health workers and specialists who are paid by government. If you look at all the faith-based facilities, the reason why their care is somehow subsidized is through the PHC grants we give them, and also extend to them health workers that are paid by government. So all those are happening, but we need to scale up and cover. The issue of regulating private health facilities really was properly cast in the limelight during the COVID pandemic, and it is something we are scrutinizing critically as the Ministry of Health, which includes, like, currently we are reviewing the Public Health Act, which was enacted in 1935, such that we look at all issues that came out during an arm and a leg, exorbitant prices. And already the court has empowered the Minister of Health to look into this issue, and it is something that is on our table as a Ministry of Health to ensure that there is proper regulated practice of our private practitioners. So I want to say that not all hope is lost. We appreciate the feedback, the comments coming out, but we are not that our system is in a disarray. No, our system is a system that is functioning, that needs continuous improvement. Train more health workers, have them deployed. In this next year's financial budget that is being discussed, already 400 billion for enhancement of salaries for medical workers has been catered for, and that is also government will. But this also comes with all set of remuneration. A senior consultant be comfortable in working roto if there is insecurity, if there is they are not able to have amenities or schools for their children. So it has to be a multifaceted approach of improving the welfare, the remuneration to attract critical staff to be in specific areas, such that we have health equity for all Ugandans. I think I can submit for now, but what I can say is that our healthcare has had an improvement, and we are leaders in some of the building blocks of a proper healthcare. Managing August ranked Uganda, the Lancet Commission ranked Uganda number 10 in the entire world. It's not just, it didn't come out of surprise. Mistakes might have happened, but we learn from these mistakes and get better. Thank you.
Right. Thank you very much, Emmanuel, for that. I want us to quickly get into how the diaspora community, the Uganda diaspora community, can take part and be, solve whatever challenges we have. I like that Francis mentioned telemedicine. It is something that we need to catch on as a country. I've been seeing Rocket Health, I think, is championing that in Uganda, and a couple of others, I think, are coming up. But I want us now to talk about you, the diaspora community. Dr. Solomon, as a diaspora community, you have given us, you've highlighted the challenges we're facing and areas we need to work upon. And very key is the standardization of costs and prices of the different services, health services that we might require. But unfortunately, diasporas are often treated as foreigners in our countries, where they are permanently settled and as aliens in their country of birth. This is something I read somewhere today. Then when it comes to investing, three words often come to mind. Now this, Emmanuel, apologies, goes to you. When it comes to investing, three words often come to mind: risky, intimidating, and scary. Yes, you've highlighted a couple of areas that the diaspora community can invest in, but I want to first speak their minds, and we shall come back to you, Emmanuel, for you to tell us how you expect, you as a Ministry of Health, expect the diaspora community to come in. I want to begin with you, Dr. Solomon.
Yes, thank you, Lynn, for that. I do not know of any healthcare worker, at least in the United States, the ones that I know, who does not have a heart or a passion to make a contribution back home. So everyone does, especially those of us that had our medical training in Uganda. We owe a constant debt, and people do things in the background in a very uncoordinated fashion, whether it's through WhatsApp consultations, as you talked about telehealth. What I think we need is a coordination, is a coordinated way in which healthcare workers in the diaspora can make a contribution back home. and it's good that we have Mr. Ainebyona here, that on day one, we would set up a diaspora healthcare workers liaison office at the Ministry of Health, where I can call and say, look, I have 1 week of vacation in Uganda or 2 weeks, and I want to give that 1 week to doing work in my area of specialty. Where can I go and how can I be helped to go to that place? Okay. Now I do those trips, and I have an arrangement with Mbarara University of where I went to medical school. So I know that, but it's not official. I just know accommodation. The university has a way in which they can pick up a professor support and actually pay for the fuel, and they get transported to the hospital to stay for. So when we need that desk, we need a transparent official capacity within the Ministry of Health in how to come and give back home. That's one thing. In terms of telehealth, I think that the referral board that the ministry has, that Mr. Ainebyona referred to, should also comprise of people from the diaspora. Okay, because I can tell you that, look, you want to transfer Mr. or Mrs. or Honorable so and so for this care, but actually that care can be adequately given in Uganda, or we can coordinate and we share or exchange notes between our specialists and then have that patient treated back home without having them to be transferred. Okay. At the beginning of the pandemic, I had close relatives who were critically sick with COVID. And what I did as a personal initiative was to contact one of my friends, a Ugandan, who was at the front line, in the New York area, treating COVID patients in the ICU. And I put him in contact with the doctor in Uganda who was treating my family members. And there was no animosity. We kept exchanging notes, the vital signs, knowing what they were, and agreeing on the basic treatment, because there was a lag where we were hit in the US much harder or earlier before Uganda was hit. So the protocols of treatment were more clear and developing in the US before they did in Uganda. So there was that very collegial exchange of information in a very informal way. So I think that can also be formalized in that way, because many critically ill patients can be managed if you have, an ICU, if you have a ventilator, you can check there, do an X-ray, every other day and things like that. And then you can have a panel of experts, which includes Ugandans abroad in the different areas of specialty. Now, there are many good things already happening. I think telehealth is a reality. I think there are several Ugandan physicians who are involved in that, from even an official commercialized status, where they offer their services, whether it's reading pathology slides, and they actually bill for that. So again, what we need is a formal system that has a government effort in it. Now, in terms of investing, I am personally involved in investing back home in healthcare, and with some of my business partners, we're able to install a CT scan in Gulu. And remember that Gulu had very highly specialized care even 20 or 30 years ago. You could go to Gulu and get radiotherapy at Lacho. There was a CT scan at Gulu Independent Hospitals, but all those services eventually drained away. Now I'm involved in some of the efforts to invest back home. And as you've said, there's risk, there's some degree of bureaucracy, but again, on a positive aspect, if you are in the diaspora and you have good local partners back home who can do the legwork, who understand the system, I think it makes it easy to invest back home in that way. The one thing that I would like Mr. Ainebyona to comment on that is very critical in Uganda today is the standardization of healthcare worker training in Uganda. Right now, we have close to about 10 medical schools, each of which awards its own medical degree. And that's not a problem. The challenge is that you need a way in which you can say every doctor in Uganda has undertaken a certain similar standardized exam before they get a medical license in Uganda. If an obstetrician has graduated from Mbarara or Makerere or Gulu, there should be a board exam they take within Uganda that says they are a member of the Ugandan Board of Obstetricians and Gynecologists. And I think that this is very low-hanging fruit. We need a board of medical specialties in Uganda that not only standardizes the accreditation of the specialists, but also ensures their continued medical education, their continued licensure. I can give you an example that every 2 years, I have to retake my exams in America for being able to perform a cardiac resuscitation of a patient who was at a cardiac arrest. Now, if I don't renew that license every 2 years, my privileges to practice medicine are taken away. So there's that built incentive that I must be licensed every 2 or 3 years to take care of patients that have advanced trauma injuries, patients that have heart attacks, stroke, things that I do not even deal with on a daily basis at all as a neurosurgeon, but as a physician, even as a medical student, or as a nurse, these are basic requirements that can be instituted so that you maintain a certain degree of standardization and also quality of the healthcare workers. Thank you.
Thank you very much, Dr. Solomon. Over to you, Miriam, before we can get back to, yes, Emmanuel. Now, Miriam, I want us to look at the fact that there are enough educated diaspora Ugandans who are capable of starting up big investments. Well, there's a challenge there. If they're given privileges, the government usually gives to foreign investors. Do you think this is one of those biggest challenges we have, or is it that the Uganda diaspora people don't really care about the country?
Most of our shows recently, there is a disconnect between the government of Uganda and the diaspora community. There is a lot the diaspora community can do because they have benefited from good training. They have access to better facilities, better opportunities, and have resources to invest back home. So if the government can just put an extra effort, for instance, to take time and say, research how many qualified doctors are in USA, for instance, the embassy can easily do that. Say how many are there, have a talk with them. Those are things that can be done at embassy level. That's more like you localize the government. You get the people to access the government where they are. So if the embassies can hold like an investment forum and maybe call people who are qualified in medical services or who want to invest in medical services and have an exchange of ideas, see where do you want to invest and how can you do that? There is a lot that can be done because the diaspora people have resources, have investment, and they can create more lucrative partnerships with more developed, say, bigger hospitals and maybe factories that are producing medical equipment and all that stuff, and that can create a bigger force which can benefit the economy back home. I don't know what Mr. Ainebyona has to say about that, but like Dr. Solomon said, if there was a desk to coordinate that, but each ministry in Uganda almost needs that because apart from the medical services, we have so many areas people can invest in. Say, Ainebyona hinted about nursing facilities. It can be about providing the much needed medical equipment. It can be about training, maybe extra training for specialized medical staff. All those things, if someone had puts in an effort, those are low-hanging fruits, like Dr. Solomon called them. But what we lack is the effort. Maybe the government doesn't believe that the diaspora community can do a lot for Uganda, or maybe they are not interested. But I would like to hear from Mr. Ainebyona what he has to say about it.
Yes, sorry, I had gone off. I think I'm having challenges with my internet. So, but thank you very much for that. Though I missed a number of them. However, coming back to Emmanuel, before we can head back to Francis. Emmanuel, you've heard from Dr. Solomon, you've heard from Miriam so far. You as the Ministry of Health, do you have any future plans or are there any existing plans at all
we have a number of investment opportunities in Uganda, mainly in the healthcare system, and these include risk pooling, which is insurance. They include remote patient monitoring, telehealth or telemedicine, and already some of our theaters in the renovated Murago have an aspect of these telemedicine facilities where our doctors, surgeons can consult their colleagues abroad in real time. We have also investment opportunities in advanced genomics. For instance, we have been doing genomic sequencing to know which variant of the COVID virus is in country. We have also investment opportunities in the detection of counterfeit drugs, tobacco control, weight management programs, better disease management, electronic medical records, better maternal and child health, health training, as earlier highlighted, and also low-cost surgery. And we have already had a department established known as multi-sectoral coordination and partnerships, which is headed by a commissioner. This is a department that can guide you on where to invest, how to go through the process. If you are going, for instance, to set up a hospital, you can consult. If you're a medical doctor who wants to come and do a medical camp, there are also guidelines under the Uganda Dental and Medical Practitioners Council. That process is on the website, how you can seek for a temporary permit to enable you conduct a surgery. All those are readily available. And that's why we really call upon whoever can to come and invest in the highlighted areas. We are going into oil and gas, the production, a lot of activities happening. Facilities are needed in the Albertine Graben in terms of better health care. There will be accidents, they will invest there. Concluded the Pharmatech exhibition. There were exhibitors from all over the world, and there was clearly available guidelines on how they can work with the Uganda Investment Authority to acquire land, to also even register their various companies, and also establish plants, and also taken through existing waiver process. So the Ministry of Health is available. There is a department in charge of ensuring there is coordination, ensuring that those ones who want to enter public-private partnerships, of course, also we expect reliable partners. We expect reliable partners who have the muscle to invest. There is one other issue that has been raised where we have challenges with the ongoing construction of the International Specialized Hospital in Ruboa. Some of these are the things we need really when we have to undertake a big investment. The investors, wherever they are ready to take up the occasion. That is much I can say, because there are delays, there are needs for further, for instance, the contractors, the financials of the whole process. So we need to have investors coming when they have what it takes to invest. And these investment opportunities are available in medicines development. We are talking of vaccine development. We are talking of genomics. We are talking of sophisticated surgery. When I talk of low-cost surgery, our patients now go for things like hip replacement, liver transplant, kidney transplant. If you can come and be part of the process of setting up, you're welcome. And the ministry is readily available to guide on how you can get started up. Thank you.
All right, thank you very much, Emmanuel, for that. I will come back to you on the issue of diaspora liaison office, Ministry of Health, that Dr. Solomon highlighted. I also come to you on involving the diaspora community in different areas. You've mentioned that if they're free to invest, they can join in, but have you engaged them? Have you reached out to them? Be answering those as I engage.
I see Dr. Solomon has typed something in the chat.
Oh, yes,
on lack of coordinated effort. There is coordinated effort. For instance, we have the UK Uganda Health Alliance that always showcases investment opportunities. Even next month, our permanent secretary will be in London to present the available opportunities. So feel free to reach us through our toll-free line, which is 0800 100 066. That toll-free line will get you to the rightful person to enable you start up a journey of investing in Uganda's healthcare system. So there is already established channels. It shouldn't be an issue of there is no coordination. We have a number of chapters. We work with embassies. As you have coordination, we had companies coming from Chuba, India, Nigeria, and all these are done in coordination with the various missions abroad. So even when you get to the nearest mission, all our missions have information on how you can invest in Uganda in all sectors, not necessarily within the health sector only.
Okay. All right. Thank you very much for that. That was actually Miriam Kyomugasho who typed in the chat room saying what is lacking is coordinated effort to reach out to these would-be investors. Now, over to you, Francis Kamuhanda. Ugandans abroad have become a major powerhouse and source of funding for mainly opposition politics in Uganda. This is one of the reasons why the government is partly treating them badly. Yet we want you people to, share your expertise, share your experience, share your knowledge, and most importantly, invest back at home. But when such things come up, we don't know how to move. Francis, what do you have to say about this?
Thank you, Lynn. I thank again Dr. Solomon and Emmanuel on being elaborate in as far as the health sector is concerned. But I have always said, like as Solomon said, Dr. Solomon said, yes, we have good policies, we have comprehensive strategies and so on, but the implementation, that is where we have a problem. And the implementation currently, it is rooted in the ulcer of corruption. I still remember we have been talking about engagement, and the engagement here should be a transparent one, should be the one which we are discussing as Ugandans, not as others are being treated as secondary citizens of Uganda. Because, Lynn, if, for example, we did not have a goodwill for our motherland, I wouldn't even be here. I would just say, okay, let me go outside there and make a couple of dollars and see how I put food on the table. Dr. Solomon would not be here. So it means that we love our country, and that's why we still think things should be better. I like the fact that Emmanuel said that when we talk about the health sector, is a multifaceted approach that should be used. I absolutely agree with him. I will give you an example. If you log into Ministry of Land, let's say if somebody wants to come and establish a hostel, I don't think that Ministry of Health is the one that will tell you this is how you can purchase land. There is a lot of corruption. I have a friend who was buying land and dealt with the Ministry of Land, which checked that this plot does exist after the person had paid 3 land titles, imagine. And so you see, all these are challenges. When we are talking about how can people be convinced to come and invest, there are a series of line ministries that we have to clarify. Like, for example, I expect that if Mr. Emmanuel has finished talking to us, for example, if some of these things which are bringing concrete evidence that can engage, we normally want to attract people to come and invest, for example, in health. But those who want to establish maybe a laboratory or whatever, they have cited problems with the land. Minister of Land, can you explain to us what do we need to do here? That's how we are going to fix some of these problems. Dr. Solomon talked about the standardized exam. I also say about curriculum enrichment. I agree, Ainebyona, they are doing it, but we are saying when we exchange notes. One day I had a private conversation with Dr. Solomon. Dr. Solomon, I'm sorry to share our private conversation. And the issue was looking for a person who is specialized in architectural design of a hospital and all these other components that are there. And it was a struggle. And remember, if you are also going to have a friend here who maybe is a foreigner, wants to join you to come and invest, they are detail oriented. The architecture you are using, is he the architecture specialized in designing maybe hospitals and stuff like that? So all these, when we are engaging and discussing with members like Emmanuel, then they will come out and then we go on streamlining our system, and that's how we shall reach a standard kind of norm. And of course, I also agree with Dr. Solomon that the curriculum does not need to remain static. Still, people in those specializations can be engaged, and then we see how we take it forward. But most importantly, the political climate, because everything that we are talking about, for sure, when it comes to investment, other people, when they hear about the political situation back home, I know it is not all that bad or extreme, but it has a lot to be desired, that nobody would like to invest in a country that seems to be politically unstable, that anytime anything can go wrong. So I would still say that, much as like I'm not saying it is not in his docket that I talk politics, but Emmanuel is not maybe a politician. But you know, sometimes when you are discussing with the political actors, tell them your actions sometimes stifle or scare away the other services that we will be getting as a country. And once we engage, constant engagement and discussing, and we see what is doable and what is not doable, I believe, Lynn, we love Uganda and we can move forward, and we can attract investors, and Ugandans can be also maybe can decide to come and invest back home. And anyway, the amount of money you said the Minister of Finance quoted, the 1.2 billion, comes from where? From people who are in the diaspora. That means they love their country, provided those remittances can still go back home. But what we are only saying is that there is nothing for us without us. Engaging us and keeping us in the loop is something that is very, very important. Like, yes, I agree with Ainebyona, at least for the website of Ministry of Health, there is when you go there and at least you find some update. Although I'm glad you talked about the act, I was also looking at it like, okay, this has been there for centuries. Is it still standing a test of time? But I'm glad you are working on it and so many other things. But also I see a big challenge is, you see, it is also, it speaks to brain drain. Whenever somebody doesn't see anything that seems to work as a medical doctor, so it is something that you should think about, because now politics back home is much more lucrative than maybe some of these sectors. A person would prefer to go and become a medical doctor or a neurosurgeon or whatever, would prefer to go and become an LC5 chairperson, because we will reap big in a short time compared to continuing the service. So that itself, we should think about it. Otherwise, we will continue going through the same circles over and over. Thank you.
Right, thank you very much, Francis. You actually, raise very pertinent issues, and I think it is a conversation that we can continue having over and over. But we are running out of time. I want to give each and every one a minute to conclude on this conversation. I want to start with you, Miriam. Your concluding remarks on what we have done and how next we can move.
Mr. Ainebyona hinted about having, a website, and the policies are there. Even Uganda Investment Authority also has a similar website. You see, these are investment opportunities and all that. But we, Lynn, from our experience, we all know how Uganda is so open to foreign investors. They would like say Bazungu, but even beyond Bazungu, but people who are foreigners. Like, for instance, the Loboa Hospital, getting all the $400 million and just giving them to some investor who has some funny details in the background about transparency, and then nothing is done at the end. All that money would have done a lot, maybe if we had, if the government had tried to invest in someone Ugandan who has a patriotic heart, instead of concentrating on foreigners. This is Ugandan taxpayers' money. We should look at our resources first, our resource personnel, Ugandans like Dr. Solomon, who have trained and have exposure how to run medical facilities and what is needed back in Uganda. Invest in those people first before you run to Cubans, whatever the list that Emmanuel was floating around, so that we have people who are committed to Uganda, people who have a national heart first, and people who really invest in their thing. Because at the end of the day, whether we are living in diaspora today or tomorrow, we are all interested in Uganda because that's where our life is. That's where, say, we plan to retire. That's where our families are. So when we are investing back home, we take care to do the best we can do compared to a foreigner who's looking at reaping profits and going wherever they are coming from. And Mr. Ainebyona, you talked about the outreach programs so far in the UK and whatever, but what I meant when I said there is no coordinated effort, for instance, we've been talking to the Ministry of Foreign Affairs and some ambassadors here. There is no registry, there is no data that shows that how many Ugandans in diaspora do you have, what type of skills do they have. That's an important database that the Ministry of Foreign Affairs should be having, which could help them to know who to reach out to, even for advice. It might not be investment in terms of money and resources, but resources as in the technical know-how. For instance, if Dr. Solomon is a neurosurgeon, you could easily direct or help the neurosurgeon department in Morago about the facilities and the equipment they need and how to do that without even having to put in money and whatever. So that's the coordination I'm talking about. Do you take care to know what type of we know so much that the Ugandan health sector has suffered a lot of brain drain because they are not remunerated back home. But how about you put in an effort to reach out to them and still tap on their knowledge, tap on their resources, and see if you can convince them to invest back home in one way or the other. It can be resource sharing, it can be knowledge sharing, it can be equipment-wise or any other way, but at least have that coordination. The embassies, the Ugandan embassies have not yet registered the Ugandans abroad, and there is no effort so far to do that. They talk about it, but nothing has been done, Mr. Ainebyona. So that's what I was talking about. Have a database of what type of people are outside there and how they can help in the development of the Ugandan health sector. Thank you. Thank you, everybody, for the good discussion.
All right, over to you, Dr. Solomon, as we wind up. I want to end with Emmanuel because he has to, give feedback on some of the issues that were raised.
Yes, thank you, Lynn, and thank you, Miriam, and Francis, and Emmanuel, and Lynn, for hosting us again. I want to pick on from where Miriam left. I'll give you an example that every month I can expect to get an email, one from the American Medical Association, two from the University of Wisconsin where I did my training, and three from the Iowa State of Board of Medicine. I get constant communication from those three. I've been away from Wisconsin for 4 years, but there's a way in which they keep in touch with every member of the associations. You know what is going on. They call for your financial support. They call for your advocacy support. They tell you what's going on in terms of policy implementation. I don't get those emails from my alma mater, Bara University of Science and Technology. I don't get any communication from the Uganda Medical Association or the Uganda Medical and Dental Practitioners Council, where I've tried to maintain my registration. By the way, you have to register every year to get relicensed in Uganda, which is a deterrent to those of us in the diaspora. And I've advocated for them to give us at least 3, even 5 year licenses. It's just a question of paying more money. But going through the same process of resubmitting certain records every single year is a deterrent. So I think that going back to Mr. Ainebyona, it's one thing to have the desks, it's one thing to have the name on paper for a department. It's another thing to actually actively engage people and make the best of those opportunities. Two is, I looked at the Ugandan embassy in DC and looked at the investment profile for healthcare. The minimum requirement for the big tax incentives are huge. It's usually a minimum of $5 to $10 million to go and invest back home to reap any benefit from those tax incentives. So that weeds out most of us Ugandans who want to come together as small groups and do something back home. So that's something that needs to be addressed as well. And then 3 on retention of physicians back home and healthcare workers. I think that there are incentives that the government can create, whether it is subsidies on mortgages for healthcare workers, or car loans, or tuition normation, things you can do without necessarily increasing the salaries of healthcare workers, but things that take away the burden of daily expenditures from them, so that way you can create more people in the service, but also retain them within their works. And finally, I want to end with this, is that whatever we do as a nation, from a social, political, economic standpoint, should have one central aim, and that is the health and well-being of its citizens and their happiness. It doesn't matter how much money you have, how many cars you have, how many skyscrapers or buildings you have. If you're unhealthy, you cannot enjoy any of those things. So I think that it should be built within every policy, whether it's education, whether it's foreign policy, whatever policy it is, the common focal meeting point should be the health and well-being of Ugandans, so that we put the dignity of every Ugandan at the topmost. Avoid this chronic big man and big woman syndrome, where everything is sort of designed to please those that are the elite in the society. And I think that once we have that cultural transition, we will make a big difference. In my hospital, the CEO and the janitor use the same toilet, they eat from the same cafeteria, okay? There's no difference in the services that we have access to. If I fall sick, I'm attended to by the same primary care physician that my patients get attended to. Whether they are homeless or whether they are millionaires, I have the same access to the same people, and we get about the same level of treatment. And I think that's a cultural transformation we also have to have in that every Ugandan, no matter what their sex is, their age is, the socioeconomic background is, that they're just as important as the president of the country.
Thank you very much, Dr. Solomon. I hope we can continue having these conversations, Miriam. And we need, I think, Something else that came up that I thought we should look into is also the Ministry of Land and the Ministry of Investment and Industry. So those are some areas we need to look at as the diaspora community, and help, come back and invest in our country and make Uganda a better country than we left it. Those of you who have left, me, I'm still here. We're doing our best as well. So thank you, everybody. We'll hope to catch you again next time, and thank you for your insights. Do keep sharing with us as and when you feel there is need, and we'll definitely be here. Otherwise, we'll catch you again next time. God bless you.
Bless you too. Thank you, Lynn.